Coming up today, frustrated at first but flourishing today. Hear what prompted one woman to switch doctors and get the care that has her living well with ulcerative colitis. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. More than 1 million Americans live with ulcerative colitis, or UC. It can get so bad that some people end up planning their lives around the disease, wondering if they'll need to skip an event, avoid their favorite foods, or stay close to a bathroom. And because UC involves bowel movements, it can sometimes be a bit embarrassing to talk about. But speaking up is the key to finding the right care. And today, we are meeting someone who advocated for herself and finally got a second opinion that changed her life. We'll ask how she's managing symptoms and about her place in Kansas Jayhawks history. We'll hear more about that in a bit. Joining us today, though, is Janet King, who went to a doctor for GI symptoms back in, this was 2018, but was probably living with UC for much longer. How are you feeling today?
Great. Very well, thank you.
Well, we're so glad to have you, and thanks for just being here with us to share more about your story. Lots to learn here. We're joined by your gastroenterologist here at the University of Kansas Health System, Dr. Shadi Hamda. Dr. Hamda has some extra training, making him a specialist in inflammatory bowel disease, which includes UC. Good morning to you.
Good morning.
What's it like to see Janet here with us this morning?
It's so good to see Janet today.
Yeah, Janet, good to be reunited. I know you're a big fan of the doc here today.
Oh, yes. Yeah, well, I wouldn't be feeling this well if I hadn't gone to him, that's for sure.
Well, we're glad you found him finally. So, Janet, take us back to 2018. Tell us about the symptoms that you were feeling. What did you do? Just tell us a little bit more about how this all got started.
Well, a very, very beginning was actually, I went to the restroom at work and had cramping and a really kind of like a severe pain, almost felt like a ripping of some sort in my intestines or my lower abdomen. But as being a nurse, I kind of was self-diagnosing, of course. And I went to my executive director, who's also a nurse, and said, something's not right. I hope this isn't the start of something, but I just had horrible pain, and that was the beginning. And then I had a very good friend, and our children were in the same school, in the same church, and he was a GI doctor. And so I called him up, and he was very good. He had diagnosed my mother's cancer. She had had some esophageal cancer, and he elongated her life. She actually didn't pass away from that. So very good diagnostic physician. But unfortunately, during this time of exploration, COVID hit. And his office shut down, and as well as everything in the world shut down, basically, United States did. And so I was being diagnosed like 2019-ish, and I was diagnosed with proctitis is what it was at first.
So,
but
Janet,
it was obviously a lot more. Go ahead.
So as a nurse, I was just curious because if somebody started to feel, if I felt some of those symptoms that you were describing, I might want to Google and start researching on my own. But as a nurse, were you thinking this might be something else? I mean, what were you thinking it could be?
Well, at 20, I had a bout of colitis, and it was after I took a real strong antibiotic. So they had diagnosed it as an allergy to a medication called Cleocin. And I was hospitalized at KU for a good probably 12 days, very, very sick. And I thought possibly I had taken an antibiotic that maybe caused this type of reaction again, is what I thought.
So how is your UC affecting your day-to-day life?
Now or then?
Yes, back then.
Then, okay. Horrible. It was painful. I was having probably 20 stools a day. So you can imagine the cramping that occurs. I wasn't having any blood, so there wasn't a GI bleed, but it was an abnormal, obviously liquidy. And I'd been through this before, very young, and I was frightened, obviously.
And you were able to take a trip overseas. You were pretty nervous about it. I think you kind of just explained why you would be. How were you able to make that happen?
Well, I had another bout, and that actually took me to the ER. And when I went to the ER, they thought I was having a kidney stone because of the pain. So they did a CAT scan, and with the CAT scan, they found that it was not a kidney stone, that it was my GI system. They hospitalized me, made me NPO, nothing by mouth, which helped a lot. So the IV fluids helped, and then they were giving me IV medication, steroids, and antibiotics, and that helped. It actually, I call it like a tune-up, taking your car in and having an overhaul. I felt tuned up. I felt ready to go overseas, or I wouldn't have gone, because ulcerative colitis and their flares are, you just really can't leave your home.
Sounds very unpredictable. But you were able to make not just a trip overseas, you went to Australia. I know that's quite a flight. We have some photos here from that trip, but I mean, great that you were able to enjoy life and somewhat manage all of this. Tell us a little bit about your trip, though.
Well, my daughter lives in Australia. She married a young man from Cerner, and they transferred them to Brisbane, Australia. And so he worked overseas. They worked over there. They moved in 2013. And my daughter is an actress, and she was in the national tour of Wicked. And then she was also in the national tour of Wizard of Oz. And so in between the two, one was ending, and one was starting, and it was in Brisbane. So it worked out perfect. And then unfortunately, my mother passed away, and she had left an inheritance. And my sister and I said, let's take some of that and let's really make a big trip. And so we decided to go to Australia and see my daughter.
I love that. Yeah, just hearing you share all of that, your life is not conducive to having this type of ailment. So I understand you wanting to try to find Dr. Hamda. How did you end up hooking up with him?
Well, it was an unfortunate situation during COVID, and I couldn't they wanted me to come in and do a colonoscopy again, and then everything shut down. So in April, they said that I could go do the colonoscopy. This was 2020. And the colonoscopy I got worse, and he wanted to talk to me about biological, and I said, I'm fine with that. Let's get it started. Well, unfortunately, through his office being closed and personnel not coming back or whatever happened, that didn't get authorized. So I limped along, and then in July, I started to get really bad. And I called again and said, where are we in the authorization? And it didn't get authorized. And so I called my primary care physician, and actually he was out with COVID. So his partner said, I said, I want to go to KU. I said, I just know I'm not well, and I'm close, and I'm really want to get down to KU and get to the next level of physicians and professionals, so forth. And she called, and I had a referral, and he's another physician there, and I couldn't see him until December. He was booked up. She goes, but they called back, and they said they have a brand new physician. He did his fellowship at Northwestern University. He did a specialization in irritable bowel disease, and they highly recommend him. And I said, fine, I'm more than happy to go and meet him, see how we react. And that's how she got me in. KU got me in. She called on I think it was like maybe a Friday, and I saw him the next Tuesday.
Well, you teed Dr. Hamda up quite well, so let's bring him in. Good to see you.
Good to see you as well.
So let's just back up and explain what ulcerative colitis is. We know we've heard of ulcers, the colon, colitis. Is it as simple as ulcers in the colon?
It is not as simple as ulcers in the colon. So ulcerative colitis is a chronic inflammatory bowel disease that primarily affects the colon or the large intestine and the rectum. The rectum is almost always involved in ulcerative colitis patients, except for a very small percentage of patients with primary sclerosing cholangitis. They can have rectal sparing. Otherwise, every ulcerative colitis patient actually will have disease in the rectum. So if the disease is only located in the rectum, we call this ulcerative proctitis, but sometimes it can extend more proximally, and it depends on the extension. If it extends to the left side of the colon, we call this left side of ulcerative colitis. Or if it extends even more proximally, more than the left side, we call this pan-ulcerative colitis.
Janet explained some of the symptoms that she was having. What are the main symptoms of this?
So the majority of patients actually will have rectal bleeding, stool frequency, urgency, diarrhea, and sometimes patients can have complications from iron deficiency, anemia, and also some vitamin deficiency. But the main symptom for ulcerative colitis patients is the rectal bleeding. Over 90% of patients can have rectal bleeding, and also urgency. About 75 to 90% of patients can have stool urgency.
So could it be something else? I mean, if you're having any of those symptoms, I would imagine you'd go see a doctor, but how do you know that it is UC or it's just something else? Or basically, how do we know to come seek out a specialist like you?
That's a great question. So chronicity is a key in ulcerative colitis patients. So a lot of diseases can mimic ulcerative colitis. A lot of things can cause inflammation in the colon, including infections, viral infections, bacterial, parasitic infections, and sometimes medications. Like I always talk to my patients about NSAIDs or non-steroid anti-inflammatory drugs. Ibuprofen, Aleve, meloxicam, Motrin, all of these medications sometimes can cause inflammation that can exactly look like ulcerative colitis or inflammatory bowel disease. So we always have to rule out other causes of the disease, and whenever actually we have evidence of chronicity, we do colonoscopy, and this is how we confirm ulcerative colitis. So again, ulcerative colitis is a clinical diagnosis, but we have to confirm with some other supportive tools like the laboratory data. We see actually increased inflammatory markers like CRP or C-reactive protein in the blood. We see increased fecal calprotectin in the stool. And again, we confirm diagnosis by doing colonoscopy and look inside the colon.
So does UC develop over time, or does something turn into UC, or do you just have it?
So it can be, first actually it can be misdiagnosed. Again, you need evidence of chronicity, but it can extend in the future. So patients with ulcerative proctitis, when we talk about the disease extension, ulcerative proctitis can extend into left-sided ulcerative colitis or even pan-ulcerative colitis. About 50% of patients can have disease extension in the future.
So misdiagnosed, or people not understanding it, does that mean that people are undertreated for it?
There are actually a variety of reasons why patients can be undertreated for ulcerative colitis. Number one, actually, patients with mild symptoms or atypical symptoms can be misdiagnosed. I see a lot of patients, they come to me, they were told that they had infection. So usually the first thing they go to the ED, they get some antibiotics. They sometimes feel better, so they don't seek medical attention anymore. Sometimes actually patients do not want to follow up, especially ulcerative colitis actually mostly affects younger people. So these patients, sometimes they learn how to ignore their symptoms. It can affect patients at any age, but we have two peaks for ulcerative colitis: patients in their 20s and patients in their 60s. So again, these patients sometimes can ignore the symptoms, and sometimes, unfortunately, undertreated patients, because what they read about, about these medications. We have now newer medications called advanced therapies, like including biologic therapies, infusions, and injectable medications. Sometimes actually you see patients are really worried of starting these medications because of the potential side effects. So this is actually where our job comes here, to try to reassure our patients about the safety of these medications and give them the accurate information. Because if you go on Google, actually you're going to see a lot of bad things. So this is not the probably best place to look for.
Not the time to Google.
Exactly.
So it's show and tell time. We've been talking a lot. We're going to go inside the body, and this is where we do want to warn our viewers. We're about ready to see images from a colonoscopy. So look away if you're not interested. But we're going to show you a before and after. Dr. Hamda, I want to see kind of what we're seeing on one side and then what we're seeing on the next. So on the left and the right.
Okay. So here you see actually, so the way we grade ulcerative colitis is based on a score coming from Mayo Clinic. It's called the Mayo Endoscopic Score. It can range between Mayo Endoscopic Score of 0, which means there is no active disease, and Mayo Endoscopic Score of 3 means severe disease. So here what you see is a severe disease. You see deep, large, huge ulcers. So this is consistent with Mayo Endoscopic Score of 3, which is the most severe disease we see. And that was pretty bad disease when I saw Janet for the first time.
So hang on these for a second, because these are the befores. How long would that take to develop over time?
So it can happen actually really suddenly, but you can see actually some subtle start and worsening over time, but you can see this actually from a get-go.
All right, let's get 5 months later. This is the after. Cleaned out.
Amazing. So this is a completely normal colonoscopy. So this is down to Mayo Endoscopic Score of 0. You see the normal vascular pattern in the colon. So this is completely normal colonoscopy.
And then we have a side-by-side, I believe. Yeah, that's what you want to see.
This is 100% improvement. Again, this is usually it takes about at least 6 months to see endoscopic improvement. And even actually when I took biopsies for Janet here, the histology or the biopsies came back completely normal. We did not see any active inflammation. For histology, it may take more time, but for Janet, actually, when we repeated the colonoscopy 6 months later, it was completely normal, both endoscopically and histologically as well.
So how do you make it look like that? If we can go back to the picture from the left to the right, how do you do that?
We have a lot of things to help our patients with, including medications. So now it is a key to start patients on treatment as early as possible. So we have a lot of medications that I say that are effective medications. They help our patients with severe disease. So back in the days, we used to use older medications like 5-ASA products, steroids, azathioprine. So these medications are not effective for severe disease. So for patients with severe disease, we have to start them on treatment with advanced therapies as quickly, as early as possible. First, to help with the symptoms, second, to heal the disease, and third, and this is actually very important, I always talk to my patients about, is to prevent complications. I tell my patients that complication risk is higher in patients with active disease, including risk of perforation, risk of hospitalization, and increased risk of colon cancer and colectomy or removing the colon.
Is what we saw there, is that a typical response?
If patients respond, actually, the medication we started Janet on is called infliximab. So patients usually respond quickly within few days. Again, since she responded, I would say this is a typical response to Remicade, but to see the histologic response usually takes more time.
Remind us of the colonoscopy guidelines. When should we be getting them?
So, guidelines for inflammatory bowel disease can be different, but for the general population, actually, we should start doing colonoscopy for everyone starting at the age of 45.
All right, we have more questions. If you are watching live, be sure to ask your questions. Use the chat on YouTube or Facebook. You can email the Medical News Network. That information is there on your screen. Janet, it wasn't too long after meeting Dr. Hamda, I think you mentioned you ended up in the emergency room here at the health system. Remind us what happened and what led you here.
Well, first, I'm going to go back when I met Dr. Hamda because he had very sketchy history from me, history and physical. So he actually diagnosed me quickly and being severe, and he even told me at our very first meeting that he wasn't sure that the medication that he was going to increase and start me on was going to help, but he was going to try. But he absolutely prepared me for the worst, and the worst was you might have a GI bleed from the symptoms you're talking about and some of the information I have from your H&P. And if so, this is what you need to do. You need to call the ER, and you'll probably get a resident if it's after hours, and he'll be able to look into the chart and we'll want you to come in and be seen right away. And of course, this is during COVID, and this is October of 2020. So, everybody's afraid to go to a hospital in the first place and sit in an ER. So that would be the last place that this nurse would want to be. But unfortunately, but fortunately, Dr. Hamda was absolutely correct, and he had me prepared on that very first visit. And so Friday night I started, this was a Tuesday, Friday night I started a GI bleed, and Saturday morning it was a full-on bleed, and I called the KU and got the resident, and the resident was well informed, and he said, you need to go to the ER. It might take a while, but once you get to the ER, they will get you transferred up to the floor. And I said, oh my, am I going to be admitted? And they said, he goes, well, it sounds like it. And I go, okay. So onward to the ER. My husband went with me. Here we are with N95 masks and surgical masks over, and the ER was packed. And back then, it was well known in the news that could be even a day before some of the people were seen at KU. But luckily, or unluckily, but I waited a couple hours, and then somebody next to me, here I am, the nurse, wasn't doing well. So I walked up to the nurse's station and said, there's a person next to me. I actually am a nurse. I graduated here a long time ago, but this person is not breathing well. I think you might want to take that person back or look at him. And they whisked that person back. That person actually had a overdose. And then as soon as they knew I was a nurse, I think they just whisked me back too. But once I got back into the ER, man, it just went like clockwork. They had an IV in me. They gave me pain medicine. And as soon as I could get a room, I was up on the floor. And I cannot tell you the wonderful treatment I got at KU. It was the best.
I love hearing your nurse instincts kicking in there, Janet. Couple more questions. You also were seen through all this by a social worker came to visit you. Why is that?
Well, multiple reasons. First of all, I was very sick, and it's very humiliating to have multiple accidents that I don't want people to clean up after me. You know, I mean, it was just, you don't want people in the room. You know, I didn't want a lot of people in the room. So I asked them to bring me the Clorox wipes or the wipes to clean my own room and my bathroom and clean up after myself, because I didn't want people in the room. I didn't want to get anybody infected. I didn't want to get COVID. I was so sick. And then I had lost my mother, who was my rock all my life. She's, we were like best friends. And even though I've had her till she was 93, losing a mother, no matter at what age, is not easy. And when you're sick, who do you want most? Is your mom. And she was always be there, no matter if it had been COVID or not. My mother would have been marching down there helping me, but I didn't want my husband down there. He has diabetes, so that was also a high risk for COVID. So I didn't want him visiting me. And then only family, immediate family could visit at that time. So it was lonely. And I went through some pretty excruciating tests when your colon looks like that. I had to do an MRI in the GI. I had to take contrast. I mean, to be explicit, I was vomiting and I was having diarrhea at the same time afterwards. I was able to hold it. Actually, the techs were amazed. They said, we've hardly had anybody ever make it through, but I held it and then immediately went to the bathroom, and just, it was so difficult to monitor. I'm sure just being healthy, but I was so sick. Going through all of that, I was just depressed. I mean, I'm sure the nurses definitely noticed. And I think being a fellow KU grad nurse and also just a colleague and a nurse, they took really special care and they were worried about me. And they called a social worker down. And at first I was, oh my gosh, am I that bad? And then after talking, I went, yeah, I'm truly that bad.
Well, Jenna, it just sounds really overwhelming. And just being sick and then talking about the mental health aspect of it all, we appreciate you sharing all of that, even down to the details of it, because these are things, this is why we're doing this show, because it's hard to talk about. Dr. Hamda, I want to bring you in too, and I know that Janet also saw a nutritionist, so there are lots of layers to getting her well, from the head down, everything. So what's it like knowing that you have this team working behind the scenes, knowing that you're here to kind of get her body healthy, but you have people that are going to help her carry this on through it when she gets home and continues on with life?
So we have actually a multidisciplinary team to help our IBD patients to get better. So this team actually involves IBD, inflammatory bowel disease specialists, we have our colleagues from surgery. Despite all the advances we have in medications, a very small percentage of patients can still require surgery to remove their colon. And the numbers are almost down by 50%, but it's not down to 0%. So surgery team also can help sometimes our IBD patients. We definitely have to hook our patients with a nutritionist or dietitianist or a dietitian. Also psychiatry. A lot of patients actually with inflammatory bowel disease can have issues with anxiety and depression. Also, social worker can be helpful to see our patients. Also, IBD, inflammatory bowel diseases, also can be systemic diseases. Patients can have extraintestinal manifestations, symptoms outside of the gut. So they can have some issues with the skin, with the joints, and also with the eyes. So sometimes also we might need help from our colleagues in dermatology, rheumatology, and also ophthalmology.
Janet, we had mentioned at the top of the show that you have an interesting spot in KU sports history. We want to get to that because you were on the KU swim team, and you were actually one of the first ever Jayhawk women to get an athletic scholarship, I understand. Tell us about this.
Well, Title IX was passed in 1974, I believe, 1974. And I had graduated in 1974. I went to Johnson County Junior College that first year, so I could stay back and swim with my amateur athletic union, which was called now it's USA Swimming team. And so just to kind of move back, I started swimming at 4, and then in Kansas City, you can imagine in the Midwest, we didn't have a lot of possibilities to swim, but I loved it, and my mother was very, very good at researching and finding pools and teams, and so I ended up winter swimming, and then just gradually got into a very highly competitive AAU swim team at the time, and we were all watching women, high school women, this Title IX going through, and so I was encouraged to write a letter by my coach to Marion Washington, who at the time was was KU's athletic director for women. And I wrote a letter and saying Title IX had passed and I would like to come to KU. It's always been my dream and I'd love to swim, but I do have other options, and people have reached out. And so she immediately got back and we interviewed, and I got the scholarship. And the other person I always say that got the scholarship was Lynette Woodward, quite a different person. She went on to the Olympics. The women won the Olympics, and then she ended up being one of the first professional women's basketball players, but she played for the Harlem Globetrotters because women didn't have the WBA at the time. So
great company
that
to be in.
The story.
That's such a cool story. I'm so glad we got to share that this morning. That's fantastic. I do want to get to some questions from our viewers, though, if we can. Pull this up. Somebody asked, what is histopically? What does histopically mean?
Histologically.
Histologically.
So
okay.
Histologically means actually when we take the biopsies and put them under the microscope, take a look and see if there are any inflammatory cells. So this is what histologically means. Okay,
question from Jean again is, you've mentioned it, you said there are several. What medications help this disease? You said we have to do an entire show on this, right?
Oh, yes.
Okay.
So nowadays we have a lot of medications. Probably since 2022, we have had actually more than 5 or 6 approval by the FDA for new medications to treat ulcerative colitis. So the older medications we have are steroids. And this is something I always talk to my patients about. Our goal is to try to take them off steroids as quickly as possible. We love to hit steroids. So these are good medications only for the short term to make patients feel better. It's not good for our patients to be on the medications for long term. After this, actually, medications called 5-ASA products come, like mesalamine, and we only use these medications for patients with mild disease. For patients with moderate to severe disease, we use advanced therapies that include both biologics and small molecules.
Jean also wants to know, is there always pain associated with this disease?
Not all the time, but pain actually can be seen over 50% of patients.
Jeremy wants to know, this sounds so familiar to people that he knows who have Crohn's disease. Is there any crossover between Crohn's and ulcerative colitis?
So they are kind of sister diseases, but there are some differences between Crohn's and ulcerative colitis. One of the differences actually is that ulcerative colitis only affects the lining of the colon. Crohn's disease affects all the layers of the colon. Ulcerative colitis, from the name, it only affects the colon, which is the large intestine. Crohn's disease can affect any part of the GI tract, starting from the mouth all the way down to the anus. So there are some differences between the two conditions.
So then Amy wants to know, what's the difference between IBS and IBD?
So there's actually a big difference between IBS and IBD. And in fact, I get a lot of patients referred to me to be seen for IBS. IBS actually, or irritable bowel syndrome, is a functional disease. So you do not see any inflammation, you don't see any ulcers or sores in the colon. It's just a functional disease, how the colon functions. Versus IBD, inflammatory bowel disease, when you do the colonoscopy, patients, you will find some active inflammation in the colon. And also symptom-wise, you do not see bleeding. Rectal bleeding, as I said, actually about over 90% of patients with ulcerative colitis can have rectal bleeding. With IBS or irritable bowel syndrome, you do not see rectal bleeding.
So do a lot more of us have IBS and not know it because
so
it's more manageable?
It's actually way more common to have IBS than IBD. However, actually, I also want to point out that there is overlap between IBS and IBD. About 1/3 of patients with IBD, inflammatory bowel disease, they can also have IBS.
All right. Last question, Janet. Stu wants to know if you've had to change any foods in your diet.
Oh, yes. Yeah, definitely. And it's interesting because if I eat some of the foods, the scare is a flare, which is really not a flare, but when you've had a flare, you worry. But beans are horrible. I cannot have beans or a lot of roughage. You would think, a lot of fiber would be the best thing, but it's just the opposite. And so instead of eating a lot of fresh fruit, I eat a lot, it would be canned fruit instead. Protein, a lot of protein. I have to be careful on milk products. So dairy can sometimes cause me to have some more, to me, it's diarrhea. I'm not getting the sores because I'm on Remicade, or I'm on now another form of Remicade. It's a newer form, and that's the Zymfentra, which is an injectable. So that just got approved by the FDA, and that has been really helpful. I give my own injections every 2 weeks, and that's helped. And I've noticed it's also helped with my the bowel regime. It's I'm not having as many loose stools as I had, but I'm trying to think of all the different things. The nutritionist was very helpful. I mean, Dr. Hamda really did a great job of setting me up with, like he said, the whole team. And to utilize the whole team is extremely important to a whole body, wellness. And I just want to also put in the plug that I had moved all my care outside of KU to KU, and I think that helped a lot, that I had all physicians that can read. At that time, the portal wasn't as active, and now it's more open, but using the MyChart portal, and the doctors can talk to me, the nurses, psychologists, nutritionists. So it's been a very great move for me to take everything from the outside hospital and bring it to KU. And then I asked specifically when I was in the hospital for a referral to a primary care physician. She has been awesome. Her name is Dr. Stolte, Sarah Stolte, and she's also in a part of the weight management program. So I joined that, and I have lost 65 pounds. So from when I started, which would have been 2021 to 2024, I'm down 65 pounds. And I'm sure that is very helpful for the GI system as well.
True.
That's true. And if I also can comment on the diet. So I always tell my patients that there is no diet that will make the disease better or worse, but diet can make the symptoms worse. So the only food that was studied, actually there was a recent French study published earlier this year, talked about, coconut water can help IBD patients. And also now we have actually more evidence also about curcumin. Otherwise, actually diet will not affect the disease, it will affect the symptoms. As Janet mentioned, actually patients with active severe ulcerative colitis, if patients have active inflammation, we ask them to try to minimize fibers, all the good stuff, vegetables, fruits, just as long as the disease is active, we try to minimize this. But once the disease gets better, we try to go back to high fiber diet.
So coconut water, and what was the other thing you said?
Curcumin.
What is that?
It's just a natural product, yeah, and this study came from outside of the U.S.
Okay.
Yeah.
Okay. Question, Jill wants to know, will the UC ever go away, or do you just live with this?
So it's a lifelong disease. It does not go away. And actually, this is a very, very important question, because a lot of patients, after they feel better on medications, they tend to stop the medications. And sometimes, we see them 4 or 5 years later after stopping the medication, they come back with more severe disease. And sometimes it's really difficult to treat the disease with any medications, and they end up having surgery to remove the colon. So I always tell my patients, if you respond to one medication, I prefer that you stay on the medication indefinitely, as long as the medication works. There is something called drug holidays. So sometimes we can, if patients are in complete remission, both the clinical, no symptoms, endoscopic, when we do colonoscopy, we do not see anything, and also histologic, when we take biopsies, no inflammation. For these patients, we can consider to do drug holiday, take them off the medications for 1 to 2 years. But even by doing this, the disease can come back within these 1 to 2 years. So our preference is to keep the patients on the medications if they respond to the medication.
Janet, we just want to thank you again for sharing your story today and just being really open and sharing all the details, because this is why we wanted to talk about this, so people feel comfortable coming forward. What do you want people to take away from your story mainly?
I would never wait. So if you feel like you have any type of symptom, it's much better to be seen and diagnosed. I know that maybe going to KU is more of an extreme, but to me, I would recommend going to KU no matter what. I don't feel like the university is an extreme. I think that it's a great environment for you to be seen and to be not necessarily cured, as Dr. Hamda said, but in remission. And I always say that, I'm in remission. There can be always things that can happen, and I might have to change medications. But so far, I've been very fortunate, and I do believe I have one of the best physicians probably in the world. I'm so grateful, and just by luck and by KU. I mean, they definitely, that front office helped me get to him, and I always recommend him, and I recommend the department and the hospital, obviously, because I was in the hospital for 10 days. So Dr. Hamda was a portion of that, but the rest of the team there, the hospitalists, the residents, the medical, everyone was superior, the techs. And I cannot tell you, the treatment I received was fantastic. And it was great to be able to be there as a patient when I went to school there, and I actually worked at KU for a year or 2 years.
Big full circle moment. And thank you for everything you just shared. And we're just so glad you had that great experience, and we're glad you're living well. Dr. Hamda, what's the big takeaway today?
Thank you. Thank you so much, Janet, for being here with us today and sharing your experience as well. And I agree, totally agree with Janet. Actually, I want patients to also to try to reach out as quickly as possible. And my big advice to patients is to try to be on the right medication from the get-go. Do not wait for 3, 4, 5 years after the damage happens. So patients need to be on the right medication from the get-go, and this is how we can prevent disease progression and we can prevent complications in the future. I want also people to know that our IBD center is probably now actually is fully equipped with IBD physicians who are specialized in IBD treatment, and we have a multidisciplinary team, so we are ready to take any IBD patients who need actually our help. We're happy to see any of you guys.
Lots of great information, but we've got lots more to share. So you're coming back.
Hopefully.
All right, sounds good. Thanks to both of our guests. Thanks to our viewers for being with us today. We'll see you back here tomorrow. Coming up Wednesday on Open Mics with Dr. Stites. Treating the prostate while preserving sexual health. I'm Jessica Lovell on the next Open Mics with Dr. Stites. The advanced techniques letting surgeons restore sexual function and protect quality of life. Wednesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.